Morning everyone, and thank you for joining us at the 9th Trials Methodology Symposium Ireland here in Cork. I'm delighted to be a part of this important gathering focused on trials that matter. My name is Anna Michalska, and as a clinical pharmacy specialist and Deputy Director of Quality Management at the Biobank of Medical University of Bialystok in Poland, my work centers on integrating biobanking into clinical and research workflows to advance precision medicine. Today, we will explore how embedding biobanks directly into routine care can make trials more pragmatic by aligning with everyday workflows, more inclusive by reaching diverse patient groups often overlooked, and more informative through robust data linkages. So what exactly is a biobank? Biobanks defined as organized collections of biological samples such as blood, tissues, DNA, and associated health data have evolved significantly in the era of big data, shifting from traditional storage-focused repositories to dynamic, data-driven ecosystems that integrate with clinical care. This integration, often termed bedside biobanking, involves collecting samples during routine patient encounters, such as clinic visits or hospital procedures, rather than through dedicated research visits. By embedding biobanking into everyday healthcare workflows, this approach aligns with pragmatic trial design that emphasizes real-world applicability, reducing the artificiality of controlled environments and making research more reflective on actual patient experiences. A biobank is more than a freezer. It's a system that links quality biological samples plus clinical data under robust consent and governance. It stores physical specimens plus the metadata needed to make them useful, and it connects those samples to electronic health records, registries, and outcomes. That linkage is what let us discover biomarkers, validate diagnostics, and design trials that reflect real patients. Do you know that despite advances in health research, only allow around 7 to 8% of eligible adult cancer patients actually participate in clinical trials? This stark statistics underscores the challenge in making trials truly representative and effective. Bedside biobanking take this a step further by integrating collection right into clinical workflows. Think drawing a blood sample during a regular checkup without extra appointments. This real-world method aligns perfectly with our symposium topic. My objective today is to explain how it enables pragmatic trials that mirror actual healthcare, promotes inclusion by reaching underrepresented groups, and makes research more informative through linked data sources like electronic health records. The integration of biobanks at the bedside, meaning the collection of samples during routine clinical encounters, such as outpatient visits, hospital admissions, represents a paradigm shift towards embedding research seamlessly into a healthcare delivery. And this approach minimizes disruption for patients, providers, utilizing residual materials, like for example leftover blood from standard tests, or targeted collections without requiring separate research appointments. For instance, initiatives like the Emerge Network link biobanks to electronic health records across institutions, enabling real-time data integration for longitudinal studies and clinical decision support. Tools such as informatics for integrating biology at the bedside, so I2B2, further enhance this by aggregating the identified clinical data with biospecimens, supporting queries for patients' cohorts, and facilitating virtual biobanks that span multiple sites. Integrating bedside biobanking into clinical care boosts inclusivity. Real-world collections methods help capture underrepresented groups often left out of traditional trials, such as the elderly, ethnic minorities, and those in low-resource areas. By embedding sample gathering, like blood draws, directly into routine visits, we lower barriers like travel demands or strict eligibility criteria that exclude up to 90% or more of diverse patients. Under integration, we can see pragmatic benefits like collecting samples during routine procedures without extra visits, which broadens access for mobility-limited groups like the elderly. For example, the Sunnybrook Hematology Biobank achieved 90% consent rates and collected over 1,000 samples from more than 700 patients. For workflow alignment, there is a minimal staff burden. 65% report no impact, paired with tailored consent for minorities like cultural sensitivity, enabled by dynamic tools for real-time updates and diverse engagement. Finally, burden reduction. Use residual materials and broad consent to cut exclusion biases, where minorities often make up less than 10% in trials. eMERGE exemplifies this by linking electronic health records to support underrepresented cohorts, making research more equitable overall. So let's discuss 3 pragmatic models for collecting samples at the bedside. Each balances yield, cost, and operational complexity. Model A is the easiest place to start. We collect leftover specimens, plasma, tissue remnants, or diagnostic swabs after the routine use. The upside is low cost, minimal disruption, and fast scale-up. The downside is variable timing and limited metadata, so some clinical windows or precise volumes may be missed. Staffing is minimal. Laboratory teams plus occasional research coordinator, support for labeling and logistics. Consent can often be managed with broad consent or an opt-out model where regulations allowed. Model B uses a small point-of-care kit that nurses or clinicians use during routine care to collect targeted samples. This gives better timing and more standardized specimens than remnants, and supports higher quality translational assays. It requires clinician training and buy-in, and adds a moderate operational burden and cost. Staffing is mostly existing nursing team and with oversight from a research coordinator, and consent is a quick bedside scripts or tiered consent documented in the electronic health record. Model C embeds dedicated research staff, a research nurse or technician in the ward. This maximized recruitment enables longitudinal sampling and complex protocol and yields the highest data quality. It's also the most expensive and needs sustainable funding and close lab support. Consent is full, in-person informed consent with options for recontact. So, just my practical recommendation, start with opportunistic remnants to build system and trust, pilot point-of-care kits in a targeted ward to improve timing and quality, and scale to embedded staff only if the scientific need and resource justified it. When we talk about real-world data linkage, the goal is to give every sample a story, to connect biological material with the patient's clinical journey, outcomes, and lived experience. So we can link multiple data sources to each biobank sample, electronic health records with diagnosis and procedures, prescription and medication records, laboratory results, imaging data, diverse registries, and mortality files. And increasingly, patient-reported outcomes and wearable device data. Together, these create a longitudinal, multidimensional picture that transforms a single biospecimen into a powerful, real-world evidence asset. Successful linkage relies on a few core principles. First, unique identifiers such as health system or NIHS number that enable accurate matching while keeping identifiers separate from research data. Second, data standardization using common data models like OMOP, so that information from different hospitals or labs can be compared and analyzed together. Third, strong governance and privacy protection, operating within trusted, audited environments where pseudonymization, access logs, and data minimization are the norm. And finally, transparency and oversight. Patients should know how their data are used and how their privacy is protected. So the diagram shows the basic flow. A barcoded sample is linked via secure identifier to the electronic record, integrated into a pseudonymized data lake, and then analyzed in a controlled environment. The key message is that linkage multiplies each sample's value. Instead of a snapshot, we gain a dynamic, contextual dataset that captures disease trajectories, treatment effects, and real-world outcomes. To conclude, bedside biobanking is not just a technical innovation, it's a system change. It bridges everyday clinical care with research, allowing us to include patients who were previously invisible in trials and also to extract richer insights from every sample collected. By combining biospecimens with real-world data and ethical, transparent governance, we create the foundation for trials that matter. Trials that are pragmatic, inclusive, and deeply informative. Ultimately, it's about returning value to patients and health system, transforming samples at the bedside into evidence that shapes better, fairer care. Thank you so much for your kind attention, and I'm looking forward for the questions.